Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. We begin with the first verdict to be handed down in the trials of the police officers accused in the death of Freddie Gray. Officer Edward Nero found not guilty of all charges today. Many legal analysts said that was not unexpected, as our Charles Robinson reports.
Jeff, I'm outside the Mitchell Courthouse where earlier today here in Baltimore, a judge rendered a verdict in the Edward Nero case. He was found not guilty on 4 counts. Judge Barry Williams, who heard the case as well as rendered the verdict, said the state had not met its burden of proof. I'm joined by Doug Colbert, who's a law professor over at the university. First of all, let's talk about this case. What did it hinge on?
Well, what it always hinges on when you're prosecuting a police officer is to see whether the evidence is strong enough to convince the fact finder, in this case a judge, but it could be a jury, that the evidence supports a conviction. And since there are so few officers, Charles, ever charged with a crime, there have been 10,000 people killed in the line of duty over the last 10 years throughout the United States, and only 54 of them were charged and only 4 convicted. So the odds are so strong that the system will protect an officer, or said differently, that it will require proof beyond a reasonable doubt that probably is going to be a higher standard of proof than for the ordinary defendant.
Doug, let's talk a little bit about what the prosecution was unable to do and talk about what the defense was able to do, if you will.
Well, I think what the prosecution wanted to do is to bring someone who could tell the judge that you cannot leave someone handcuffed and shackled and face down in the back of a metal police van inches away from the wall and consider that you've protected your prisoner. And so I would have liked to hear from officers or officials or retired officers who would have told Judge Williams that this is not following the general order, this is reckless endangerment, this is leaving someone's life and well-being in jeopardy.
Now, the defense constantly said that what a reasonable officer would do. Is that really what it hinged on?
Well, the definition of whether it's a reasonable officer who does what the other officers are doing, or whether the reasonable officer is someone who's doing what he should be doing, following police rules, is 2 different definitions of reasonableness. I like to think that the reasonable police officer follows rules, follows law, protects people that they take into custody, do not make arrests when they don't have probable cause. That's the way a reasonable officer should conduct himself, not the way other officers might do things.
Doug, thanks a whole lot for joining us. Just want to let you know there are 5 more trials to go. We're going to have 1 retrial of Officer William Porter, and then, of course, we get Officer Cesar Goodson, who was the driver of the van. Now back to you in the studio.
In the studio for this week's Your Health segment is Dr. Bradley Taylor, Associate Professor of Surgery at the University of Maryland School of Medicine, Director of Coronary Revascularization at the University of Maryland Medical Center. Doctor, thank you for being with us.
Thank you for having me.
You perform all manner of cardiac heart surgeries, but let's start by focusing on a procedure you did today, replacing a valve, an aortic valve, without opening the patient up. How does that work?
So transcatheter aortic valve replacement is a relatively new therapy that's being offered. Instead of opening a patient's chest through a standard sternotomy, we now can access their vascular space with just a needle and a wire, very similar to a heart catheterization. Once we get that wire into place and then cross the aortic valve in patients who have severe aortic stenosis, or a very tight valve that basically checks the blood as it leaves the heart, we can then deploy a new valve, basically moving the old valve out of the way and putting a new valve in that space. It takes The case today took us about 45 minutes. It was a 92-year-old gentleman whose risk profile was too high to do it as an open operation, and I just left his bedside, and he's having dinner. He's already walked the floor in the hospital and probably go home in a day or two.
That's a remarkable thing. So the alternative to that procedure 10 years ago,
well, probably
if you couldn't operate, it would have been
either open surgery, extremely high risk, with potentially long ICU stay, and a lot of work on the patient's part, to recover, to now a procedure that's fairly straightforward and being performed across the country in a variety of different hospitals.
Who's a candidate? You mentioned people who might not be able to tolerate the open surgery.
That's correct. So it's a relatively newer device, and so we initially started studying these devices in basically prohibitive risk patients who couldn't undergo an open operation and were turned down for surgery. We've now studied in high-risk patients and in what we call moderate-risk patients who it's actually shown to be beneficial in. And we're at the point now where we're starting to study the valve in low-risk patients, basically people who would be candidates for an open operation that we know would do very, very well with an open operation. But because it's so revolutionary, we think that it'll be beneficial for basically most patients who have severe aortic stenosis.
Would you rather be able to do it as an open procedure in terms of knowing that it was exactly in the right place and it was a repair that was going to last for decades and decades?
Well, it depends. So again, these devices are under study, so we want to make sure that what we're giving patients is a durable operation, something that will last a good long time. So in patients that are higher risk or older patients, giving them a device that will extend their life without putting through much risk is clearly beneficial. In the younger population of patients, or patients who clearly will tolerate an operation, we want to make sure that we're not giving them just a series of short-term therapies that will have to be repeated time and time again. But it's something that's being looked at clearly right now.
Let me remind our viewers, if you have a question about the latest advances in heart surgery, you can give us a call. We'll have the number up on the screen. You could also tweet your questions. The Twitter address is @MPT News. In the course of a year, how many and what kind of procedures do you normally do?
So you're asking myself
as
personally?
An individual.
Yeah. So at the University of Maryland Medical Center, I do somewhere between 450 and 500 operations a year. It's a lot. So I'm a very busy cardiac surgeon.
And the full gamut of heart issues?
That's correct. I'm an adult cardiac surgeon, so I do coronary artery bypass grafting. The majority of my operations that I do are coronary surgery, but I also do aortic valve replacement, mitral valve repair, and I do a number of operations on the thoracic aorta.
You were kind enough to bring in aorta with you, which, frankly, you can hold it up and maybe show us where it fits in with the body. But you were telling me that's roughly the actual size.
That's correct. This model is of a human aorta, and this is essentially the arch portion of that aorta with the blood vessels that go off to the right side of the brain and the right arm, the left side of the brain, and then the left arm, as you can see here. This model then has a depiction of an aneurysm. This is about the size of a normal aorta. Your aorta should be about 2.5 centimeters in size, which is about that big around. But
so the things that shouldn't be there, the aneurysms that you talked about on the left and right, and the device in the middle, the white tube, is the repair.
That's correct. So similar to that transcatheter aortic valve that we were talking about, we can repair aneurysmal disease both in a transcatheter fashion. Again, getting access at the femoral arteries or at the groin with a needle and a wire, and over that needle and a wire, once we get that wire across the disease segment of the aorta, we can then place a device. The device almost looks very similar to a fishing rod. You track that fishing rod up into the aorta. As long as we have about 2 centimeters of healthy aorta, we can land the device and then exclude the aneurysmal or disease segment of the aorta. Essentially, we're just relining the aorta with a new series of plumbing.
Amazing. I want to ask more about that, but let's grab a phone call. Baltimore City, this is Fran. Fran, thanks for the call. Go ahead.
Yes, I want to ask, I have a branch bundle heart, and I would like to know that I'm on a medication called Biostolic, and how long do I have to be on this medication? For a short period of time or a long period of time, and does the valve have anything to do with my heart?
Fran, thank you. Good luck. We'll get you an answer on the air.
Yeah, so as far as her medications, and I think the best thing to do is get her to see her physician because bundle branch block or that condition related to the heart can be a situation where somebody, an expert, particularly somebody who's an electrophysiologist who understands the electrical system to the heart, can answer that question in probably a much more concise and solid way.
Looking at your model aorta, the aneurysm that you described on the sides of it doesn't look like that big a deal, but it's a very, very serious condition.
So the majority of aneurysms are picked up by just routine CAT scan or chest x-ray. People develop aneurysms and they don't know they have them. It's typically a disease of the elderly and of smokers, but they silently grow over time to the point where oftentimes the first time somebody knows they have an aneurysm is when they rupture or they're in an acute emergence situation, and that blood now is leaking from outside their aorta into either their pleural space or the tissues around those blood vessels. Most patients probably don't even make it to the hospital. 90% of patients will die unseen once that aorta ruptures if they don't get medical help quickly.
Are there any symptoms that's going on? And does that, you mentioned some of the risk factors, does it run in families at all?
It clearly does run in families. So it's one of those things. So if your family members had a history of aortic aneurysm disease or what's called aortic dissection, you should be screened and looked after carefully because they do run in families.
We talked a few weeks ago about a screening test becoming more popular called calcium scoring or something, calcium scan perhaps.
That's right.
How does that fit into heart disease?
So patients who have calcium scans, or one of the things we look for, that when a blood vessel, the aorta, the coronary arteries is injured, it will lay down calcium in its attempt to repair itself. And over years, a lot of times with repeated injuries, you develop more and more calcium buildup in those areas. So by screening for it, by doing a CAT scan or looking at x-rays, you can see where that calcium is, and it gives you an indication that that patient may actually have a problem that's worse than they may be aware of. They may be asymptomatic and silently developing a problem in their, if you think about your aorta and your coronary arteries, your internal plumbing.
And it's coming into favor because it's quick, relatively low radiation dosage.
That's correct, and it's painless. It's an easy way to screen patients.
Let's take another phone call. Cecil County, this is Virginia. Virginia, thanks for calling. Go ahead.
Yes, hello. My husband has an aortic aneurysm. It's been measured between 5.5 and 6. He has other health issues, and we're wondering if this new technique would be beneficial to him.
Sure.
Virginia, we'll get you an answer on the air. Thank you very much.
Can you tell me where that aneurysm is located?
Virginia, are you still there? Yeah, I think I lost
she's
her.
not there. But
Yeah.
what's important to answer that question is, so between 5.5 and 6 centimeters, no matter where that aneurysm, it should be evaluated and looked at. Across the country, surgeons will take care of patients who have aneurysms of that size. It meets criteria to be operated on. If he has other health issues, clearly we could evaluate him and look at him and probably offer him some form of therapy.
Okay, and I'm sure Virginia's still listening. Best way to get in touch with your center?
To call the office. I can provide that phone number if you'd like.
Sure, go ahead.
Sure, it's 412-328. I'm sorry,
Probably
it's
410.
not. It's 410, 410-328-5842. I don't call myself very often. It's 410-328-5842.
Or call the University of Maryland Medical Center, ask for Dr. Taylor.
Yeah.
Let's talk to Jim in Baltimore City. Jim, thank you for calling. Go ahead.
Okay. Hi, Dr. Taylor. It looks like a great procedure. Does this allow you to save resources like blood and blood products, or treat more people, or do it more efficiently?
Absolutely. So if you look at patients that have, we use the term percutaneous access for repair of their aorta, for their for their aortic valve. Those patients rarely require blood transfusions, and so And the safety profile is in the majority of patients a lot lower. If you can imagine, having just access to a blood vessel versus opening the chest fully, it obviates the need for using the bypass machine, keeping people off the bypass or the pump as we refer to it, and it's a lot less invasive. So it's in the majority of patients, it decreases the amount of time they actually spend in the hospital. So it's been clearly beneficial.
You mentioned before the large number of procedures that you do of all types in a given year. Is that common for heart surgeons?
So the average cardiac surgeon in the United States probably does somewhere between 150 and 200 open heart operations. I happen to be at a locale where we have access to a large population of patients that range all the way from West Virginia, Northern Virginia, Delaware, South Central Pennsylvania, and I've just been fortunate enough to be in an area where we have access to a number of patients.
Is there a number or analysis that would show that a certain volume is a good thing to look for in a surgeon?
Sure. So actually, studies that came out in the late 70s, particularly out of Stanford, showed that volume, that surgeons that are high volume surgeons have better results than surgeons who are of lower volumes. And if you think about it, that's because there's a system in place, there's experience in place that creates that situation.
Let's take a call from West Virginia, Martinsburg. This is Emmanuel. Thank you for calling. Go ahead.
I was wondering if this is a procedure that could work for patients with atrial fibrillation.
So this procedure per se wouldn't work for atrial fibrillation, but there are procedures, and they're again, electrophysiologists are experts at a variety of different centers who can treat atrial fibrillation in the cath lab using catheters and wires. There are also surgical procedures. Oftentimes they can be done through just small incisions to basically block the focus of where that atrial fibrillation is beginning in the atrium to prevent it from spreading to the rest of the heart.
Dr.
So
Brad
options.
Taylor, surgeon, University of Maryland Medical Center. Sir, thank you for being with us.
Thank you very much for having me.
We appreciate it. Tomorrow night at 8 o'clock here on MPT, we begin a 3-part series, Maryland-Vietnam War Stories. Here's a preview.
Walking Point was very, very scary. You've got everybody behind you, and particularly where we were at. We were in the jungle where sometimes it was so thick, the only way we could get through it was with a machete. Okay, so you're going through, and you're actually leading the way, and you're cutting this elephant grass down that's over your head. So you can't really see it to the left of you, you can't really see it to the right of you, but you're just cutting a path going through. Normally, if the enemy is out there, that guy at Walking Point, he's not going to be in pretty good shape. I mean, it's a real scary job. But some people volunteered for it. Sometimes they actually had to say you were going to walk point. I probably walked point 2 or 3 times, and I did not like it. I mean, I didn't see any longevity in walking point at all. One of the reasons I actually took the machine gun is because if you had the 60, you didn't have to walk point.
You have a point person, and I'd have a second person behind them. A point person looking straight down at the trail. Even though there weren't a lot of booby traps, you wanted to look real close at where you were stepping. And the second person behind them looking higher. Humans don't look up. People do not look up, and you can try it, and it's one of the reasons deer stands, maybe it's mammals don't look up.
What they would do is they would belt themselves up in a tree. So you'd take fire, you'd return fire, and the only reason you know they were dead is if they fell out of the tree or they dropped their weapon, because they'd strapped themselves up.
In the studio now is the program's executive producer, Ken Day, and Fred Shinbur of the Maryland Veterans Commission. Fred is also a Vietnam veteran and project coordinator here. Let's set the stage a little bit more. It's been 50 years since the beginning of the Vietnam War. Presidents in Vietnam as we speak. MPT has been planning this for some time with a major event coming up in about 4 weeks. Tell us big picture. What are we doing, Fred?
Well, we're trying to do it just for that. It's been 50 years since many of the Vietnam veterans came home, and were not recognized by our society, by our community. And Maryland Public Television decided that Maryland should take the lead and to provide the recognition and the honor and respect that the Vietnam veterans did. So they got together and they developed plans for a documentary and a venue to celebrate their homecoming.
Documentary is really the centerpiece of the station's efforts. Ken Day has been in charge of this. Tell me how you decided how you were going to tackle something this big.
We were inspired by a sister station. Wisconsin Public Television had done something similar to this 6 years ago. 3 hours, first hour early advisory years, second hour huge escalation to where we had as many as 500,000 troops over there in 68 and 69. And then the third hour, sort of the drawdown, when we began to attempt to turn it over to the Vietnamese, the Vietnamization. So finding all these soldiers was not easy. The techniques is also that I'm having the personal stories of the soldiers tell the story of the war. So consequently, there's no narration, because as soon as I put a narrator in, this was a very divisive time, just like now. And I'm sure if I put a script in here that I wrote, I'd be having calls the next day saying, that's not how it happened. But when it's coming out of the mouths of the vets, it really is what they truly experienced.
And I've met a number of the people you interviewed, and you did these interviews about 5 feet from here. You had the advantage of having talked to some really extraordinary people who had incredible stories to tell and didn't need some narrator getting in the way.
That's right. They were powerful stories. The show is powerful. It's poignant. It's very informative for so many people, particularly younger folks. They say the average high school history book devotes 2 pages to Vietnam. It was America's longest war, 10 years until Afghanistan came along.
And people wanted to forget about it immediately.
That's right.
Did you have any trouble getting people to talk? Were they reluctant? Were they anxious? What
Generally,
did you find?
we had what was called a listening session, and if they wouldn't talk, they wouldn't even come to this. But basically, we asked them to tell us a few of their experiences, told them about the project that we were developing, and then we basically invited them in for a long-form interview. And usually within the course of that hour, and you have to understand, some of these stories, they hadn't even told their wives or kids in 50 years. But a lot of them are beginning to realize it's 50 years and they're not going to live forever. Some of them said basically, if I don't tell my story now, I may never tell it. So I felt honored that they actually shared those stories with me and then, in essence, with our audience.
Is this documentary, who's the intended audience for this?
Oh, it's pretty wide-ranging. As I mentioned, there's so many younger folks, and this is pretty compelling stuff. So we have incredible stories, incredible footage from the National Archives to kind of accompany those stories. It's really, certainly for the baby boomers, because we all remember this period. It was very divisive. But it's also for the 35, my editor said, I had no idea that this happened. And it was quite a compliment. He really was quite happy to learn as much as he did in the 10 weeks it took to edit this thing.
Fred, 4 weeks away, Father's Day weekend, LZ, Maryland, at the State Fairgrounds in Timonium. 2-day event. What's planned?
Well, there's so many components to this, Jeff. Just some of the highlights, if I may. Our intent is to recognize and celebrate the 58,307 that are on the Vietnam Veterans Wall down in D.C., but we're focusing more on the Marylanders. So we intend to do several of our activities surrounded those 1,017 Marylanders that were killed in action in Vietnam. We will have the Wall That Heals, which is a 50% replica of the big wall downtown, that we'll have it on site, and folks will be able to take the paper and rub the names off and take them home with them. We'll also have a tribute to specifically 1,017 in the form of white chairs, all laser aligned like the headstones at Arlington Cemetery, one representing each Marylander killed in action. But a big piece is the fact that we're going to have an honor ride. We dubbed it the honor ride, where it's going to be 1,017, hopefully, motorcycle riders right into an 11-mile ride right into Timonium to the fairgrounds in honor, one representing each killed in action.
So more information on all of this at our website. Fred, where should somebody look?
mpt.org/Vietnam.
And in terms of showing up, or they're inexpensive tickets, veterans are free.
All veterans, active duty are free. 12 and up are $5 for both days. Days.
Everybody should take a look at that. Everybody should tune in for the program beginning tomorrow night, Ken, running for the next 3 nights here on MPT. Highly recommended. Ken and Fred, thank you very much.
Sure. Thank you for the opportunity.
Good work. Thank you for joining us for Direct Connection Thursday at this time on Your Money and Business. Getting a big deal on a small hotel room. That's Thursday at 7:30. Now, for all of us here at MPT, I'm Jeff Salkin. Thanks for watching Direct Connection, and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.